What a stroke looks like the day before it hits. Know this to protect yourself. Every 40 seconds, somewhere across our vast planet, a person succumbs to a stroke, meaning that by the time one finishes reading this very sentence, another brain has already been irrevocably impacted. Annually, this devastating cerebrovascular event claims the lives of nearly 6 million individuals worldwide, solidifying its rank as the second leading cause of death, and perhaps even more significantly, the number one reason why people find themselves living with permanent disability. However, there's a crucial piece of information that is often overlooked or not communicated with sufficient clarity. In a vast number of these cases, the brain generously provides very specific and discernible warnings, often hours or even days before the onset of a major, debilitating stroke. The challenge lies not in the absence of these warnings, but in our collective inability to recognize and interpret them for what they truly are. It's imperative to understand that a stroke is not merely an abrupt, unforeseen catastrophe where one minute you're fine and the next you awaken in a hospital bed without warning. On the contrary, in the majority of instances, a stroke represents the predictable culmination of a long-standing process where the intricate network of blood vessels nourishing the brain has been gradually deteriorating for many years. If an event is predictable, then by its very nature, it is at least partially preventable. And illuminating this crucial aspect of stroke prevention forms the very essence and purpose of this comprehensive discussion. When most people speak of a stroke, they are in fact referring to two fundamentally distinct types of events that can occur within the brain, each
with its own unique underlying mechanism and clinical implications. The first type is known as a hemorrhagic stroke, which occurs when a blood vessel within the brain ruptures or bursts. This allows blood to spill into or around the delicate brain tissue, subsequently forming a clot that exerts compressive force on the surrounding neurological structures. The consequences of such an event are often dire, with a significant number of patients succumbing to their injuries. The second, and far more common type, is an ischemic stroke, where a blood vessel does not tear but rather becomes blocked. This blockage interrupts the critical flow of blood to a specific region of the brain, leading to a rapid cessation of oxygen and nutrient supply, causing brain cells in that deprived zone to begin dying within a mere 4 to 6 minutes. Ischemic strokes account for approximately 85% of all stroke cases, and as such, will be the primary focus of our detailed exploration. To truly grasp why every single minute holds such immense importance during an ischemic stroke, one must appreciate the incredibly demanding nature of the brain itself. Although the brain weighs a modest 1.44 kilograms, constituting only about 2% of your total body weight, it consumes an astonishing 20% of all the oxygen you inhale, and roughly 25% of all the glucose circulating in your bloodstream. It operates as an unceasing control center, never powering down, and thus requires an absolutely constant and uninterrupted supply of fuel. Interrupt that vital fuel line for even a few brief minutes, and brain cells begin to perish in ways that are, tragically, irreversible. This profound time sensitivity is precisely why medical professionals emphatically declare that stroke is a race against time, a literal race to salvage precious brain tissue before it is permanently lost. What many individuals fail to comprehend is that for a brain artery to suddenly block, the underlying conditions and damage have typically been accumulating for years. The walls of these crucial vessels have been subjected to damage, cholesterol and various clotting factors have been steadily building up, and the internal opening of the artery has been progressively narrowing. This is not an instantaneous, unprovoked explosion, but rather the inevitable final step in a prolonged, insidious process. Along this treacherous path, the body frequently transmits early warning signals, yet the fundamental problem remains that very few people have ever been educated on how to properly recognize and interpret them. In the realm of medicine, these critical early warning shots are medically termed a transient ischemic attack, or TIA for short. The term transient simply denotes temporary,
These episodes come and go, often vanishing as quickly as they appear. To visualize this, consider a carotid artery, which is the principal artery located in your neck responsible for transporting blood from your heart directly up to your brain. Over a span of many years, a fatty plaque composed of cholesterol and other cellular debris gradually forms on the inner wall of this artery, particularly at points where it branches. This accumulation causes the opening of the artery to slowly but inexorably narrow. Then, at some critical juncture, the already constricted vessel may go into a brief spasm, causing blood flow to momentarily cease for a few seconds or at most a few minutes. During this temporary cessation, the specific area of the brain fed by that particular artery essentially blacks out, leading to the manifestation of a stroke-like symptom. Subsequently, the spasm relaxes, blood flow is restored, and the symptom recedes, often leading the individual to mistakenly believe they are perfectly fine again. However, extensive research unequivocally demonstrates that a transient ischemic attack very often serves as a direct precursor to a major ischemic stroke, typically occurring within the subsequent 72 hours. This critical 3-day window represents a precious opportunity during which a potential disaster can still be averted. Regrettably, the majority of people fail to utilize this vital window, largely because the warning episode was brief, perhaps confusing, and then seemingly resolved itself. Consequently, they often rationalize away the experience, convincing themselves not to take it seriously. These crucial warning episodes usually persist for a very short duration, ranging from approximately half a minute to perhaps 10 minutes, which is precisely why they frequently go unheeded. One might be engaged in a mundane activity, in the kitchen, showering, or exiting a car, and by the time one pauses to reflect, the symptom has already passed. Yet each of these fleeting episodes is your brain sending a final, unequivocal message: I am on the verge of serious trouble. It is therefore vital to understand the 5 major red flags, not only what they look like from the outside, but also the underlying physiological events occurring within the body each time. The first profound warning sign manifests as temporary blindness in one eye. This phenomenon can occur quite suddenly. You might rise from a chair, walk towards the kitchen, and abruptly one eye becomes dark or takes on a foggy appearance, akin to someone drawing a black curtain over your vision or smearing the lens with gray mud. Instinctively, you might blink several times or perhaps rub the affected eye, and within a matter of seconds, or a minute at most, your vision miraculously returns. Understandably, many individuals attribute this to trivial causes, such as standing up too quickly or excessive screen time. However, the stark reality is that this curtain effect is almost invariably caused by a minuscule clot or a small fragment of plaque that is detached from the wall of your carotid artery. This fragment then travels upwards and temporarily plugs the tiny artery responsible for feeding blood to your eye. It is crucial to comprehend that the artery supplying your eye is not some isolated, random tube. It is a direct branch stemming from the inner carotid artery, which is the primary conduit for blood flow to your brain. When this clot or plaque fragment temporarily lodges itself into that minute eye artery, blood cannot pass through effectively. As a result, the retina, the highly sensitive, light-sensing tissue at the back of your eye, experiences a momentary loss of its blood supply, causing you to perceive darkness or a blurred smear instead of a clear image. When the clot naturally drifts away and blood flow is subsequently restored, vision returns, often leaving the individual feeling fortunate. And indeed, they were profoundly lucky, because that precise same clot could have traveled merely 2 millimeters to the side into a vital brain artery. In such a scenario, instead of a fleeting 1-minute blackout in a single eye, the outcome could have been permanent loss of speech, paralysis affecting an entire arm and leg, or even death. Medical professionals have a classic Latin term for this singular eye blackout, amaurosis fugax, which literally translates to fleeting blindness.
Neurologists universally treat this descriptive phrase as an urgent fire alarm. If a patient presents with a description of such an episode, they are immediately placed under urgent medical evaluation, primarily because the imminent risk of suffering a full-blown stroke in the ensuing hours is alarmingly high. Hospital records consistently reveal a disturbing pattern where individuals regrettably dismiss 2 or 3 of these seemingly benign eye episodes, only for the very next occurrence to be the big one, a major stroke impacting the brain itself. The second critical warning sign to be aware of is the sudden onset of numbness or a tingling sensation on one side of your body. The medical term for this phenomenon is paresthesia, but it can be more readily understood as your skin experiencing a peculiar, drunk sensation. This sensation can encompass an entire arm, be confined solely to the hand, affect half of the face, or even extend to one complete side of the body. It is often described as feeling like pins and needles, a cotton-like dullness, or as if the affected body part has transformed into rubber. The paramount detail here is that this sensation appears entirely out of nowhere, without any apparent trigger, while you are engaged in everyday activities such as sitting, walking, or conversing. It typically persists for a few minutes before spontaneously resolving. Many individuals have likely experienced temporary numbness from sleeping on an arm, where nerve compression causes a sensation that clears up once movement is restored. However, this is fundamentally different. In the case of sleep-induced numbness, your brain and spinal cord remain unaffected. The issue is localized to a squeezed nerve, and sensation returns quickly as blood flow and position normalize. With a TIA, the problem is not within the limb itself, but originates in the specific area of the brain responsible for mapping sensation from that limb. And critically, the episode bears no relation to posture or body position. Another crucial aspect worth noting is that stroke symptoms are almost invariably one-sided, because each hemisphere of your brain primarily controls and registers sensation from the opposite side of your body. Therefore, if both hands experience numbness evenly, this more often points to issues related to the neck or spine. However, a sudden, unilateral numbness that resolves after a few minutes serves as a compelling reason to seek medical evaluation for a possible TIA and assess your overall stroke risk. The third significant warning sign involves a sudden loss of coordination, frequently described by affected individuals as a drunk walk, despite having consumed no alcohol whatsoever. You might be navigating a flat, familiar surface, and inexplicably your foot lands in the wrong place. Your leg could feel unexpectedly weak or rubbery, or you might stagger into a wall momentarily. Alternatively, you might be overwhelmed by a sudden, intense spinning sensation, compelling you to grasp a nearby chair or door frame, even though you have not actually been spinning, nor have you abruptly jerked your head or just stood up from a prone position. The intricate part of your brain responsible for maintaining balance and orchestrating smooth, coordinated movements is called the cerebellum. This vital structure is situated low in the back of your skull, resembling a small, supplementary brain. It operates tirelessly, constantly calculating your body's precise position in space and meticulously calibrating the force with which each muscle should contract, ensuring that you walk in a straight line rather than a zigzag pattern. The cerebellum receives its essential blood supply from arteries that ascend through the bones of your neck and into the back of your head, a network collectively referred to by doctors as the vertebro-basilar system. If blood flow within these crucial arteries diminishes sharply, even for a mere few seconds, the cerebellum essentially glitches. This is when you might suddenly veer sideways, make an unexpected misstep, or experience violent dizziness without any discernible external cause. In clinical practice, a prevalent pattern emerges where people tend to dismiss these episodes, attributing them to factors like bad shoes, general fatigue, or fluctuating blood pressure, only to discover much later that these were, in fact, cerebellar transient ischemic attacks. Benign forms of dizziness typically have a clear, identifiable trigger, such as rolling over in bed, rapidly turning the head, or a pre-existing inner ear condition. In contrast, spontaneous, intense dizziness, coupled with any difficulty walking straight, should be treated with utmost seriousness as a potential TIA, until a medical professional conclusively rules out a vascular cause. The fourth crucial warning sign is observed in your speech. Before delving deeper, it is important to clarify a common misconception. If you occasionally struggle to recall your neighbor's name or temporarily forget a common word like toothbrush, these are generally not indicative of a stroke. These are normal, tip-of-the-tongue moments that tend to occur more frequently when one is tired or under stress. What genuinely concerns neurologists, however, is something entirely different. When your speech suddenly and dramatically breaks down to such an extent that even you, the speaker, perceive that something is profoundly wrong. In the majority of individuals, there are two primary speech areas located in the brain, typically situated in the left hemisphere. One of these regions, frequently referred to as Broca's area, plays a pivotal role in helping you formulate words and transmit clear, precise instructions to the muscles of your tongue, lips, and jaw. When this critical region experiences a loss of blood flow, you may perfectly comprehend everything others say to you and know precisely what you wish to articulate, yet find yourself utterly unable to produce the words. Your speech may emerge as slurred, chopped, or simply stuck. The other vital area, often known as Wernicke's area, is instrumental in helping you understand spoken language and organize your own sentences into coherent, meaningful expressions. When this particular zone is compromised, an individual might speak fluently, yet their utterances consist of complete nonsense, akin to a word salad, and they may simultaneously struggle to comprehend even simple phrases directed at them. If any of these distinct speech problems manifest abruptly and then subsequently fade after a few minutes, this is a classic presentation of a TIA and should not be casually dismissed as mere fatigue. It is perilous to disregard broken speech simply because it's self-corrected. This would be analogous to your home alarm system activating, then silencing itself, and you concluding that it was probably nothing significant. The fifth warning sign is often less obvious and tends to surprise most people when it is introduced. It represents a unique combination of certain skin changes coupled with the emergence of new, unusually strong headaches that deviate from one's typical headache pattern. The specific skin condition involved is vitiligo, characterized by patches of pale or completely white skin where the pigment-producing cells have ceased to function. Vitiligo is fundamentally an autoimmune process, meaning that the body's own immune system erroneously begins to attack its own pigment cells, perceiving them as foreign invaders. A crucial insight here is that when your immune system goes off-target in such a manner, it frequently does not confine its assault to a single organ. In a significant number of individuals, that same underlying autoimmune process can silently inflame the delicate inner lining of blood vessels throughout the body. This inner lining is known as the endothelium, a microscopically thin layer of specialized cells that coats the interior of every artery, functioning like an incredibly smooth, non-stick surface. When the endothelium is healthy, blood components glide seamlessly past, and nothing truly adheres to the vessel wall. However, when it becomes damaged by inflammation, it transforms into a rough, scarred surface, providing an ideal environment for various substances to cling to. This includes cholesterol, platelets, and different inflammatory proteins, which over time accumulate to form the initial seeds of plaques and clots. It is important to note that vitiligo in isolation does not automatically doom you to a stroke. But if on top of having vitiligo, you begin to experience frequent, unusually intense headaches that do not conform to your usual headache patterns, this specific combination warrants a thorough vascular workup by a medical professional rather than a passive wait-and-see approach. Headaches in general are notoriously tricky to diagnose because a multitude of people mistakenly attribute them to issues with blood vessels when the true problem lies elsewhere. A very common cause of chronic or frequent head pain, for instance, is the wear and tear that occurs in the small joints located between the second and third neck vertebrae, essentially a form of arthritis in the neck. This degeneration of the neck joints can irritate nearby nerves, transmitting pain upwards into the head, a phenomenon entirely unrelated to a blocked brain artery. Furthermore, many individuals may harbor an undiagnosed neck disc herniation, and if left unaddressed, in severe cases, it can jeopardize the nerve supply to the arms or legs. Headaches should never be merely suppressed with long-term pill usage. They necessitate a careful decoding process with a doctor, especially when their character changes or when they present in conjunction with other warning signs, such as the ones we have just explored. Let us now delve into the fundamental mechanisms that genuinely inflict damage upon your blood vessels from the inside, as this is where one of the most pervasive myths concerning stroke risk resides. This myth often states, "My cholesterol is normal, therefore I am safe from stroke." The reality is far more nuanced. Stroke risk is not solely determined by what substances are circulating in your blood. It is, perhaps even more critically, profoundly influenced by the actual condition of that delicate endothelial lining on the inside of your blood vessels. Revisit the non-stick pan analogy. As long as the protective coating remains intact, food does not cling. However, once that coating is scratched and damaged, everything begins to stick and burn. The first and arguably most significant enemy of the endothelium is chronically elevated blood sugar levels. Glucose, in its fundamental role, is the primary fuel for your cells. Yet for glucose to transition from the bloodstream into the endothelial cells, it requires the presence of insulin, a hormone that essentially acts as the key to open the cellular door. When your body either fails to produce sufficient insulin, or when your cells develop resistance to its effects, you can have an abundance of sugar circulating in your blood, while, ironically, the cells lining your vessels are still starving. Starving cells become damaged, lose their characteristic shape, and can even begin to peel off the inner surface of the vessel, leaving behind rough, scar-like patches. These scarred zones subsequently lose their vital ability to contract and relax properly in response to changes in blood pressure, a condition doctors refer to as a loss of vasomotion reserve, signifying that the vessel has forfeited its crucial flexibility. Furthermore, these rough, damaged spots become perfect landing pads for what is commonly termed bad cholesterol, specifically low-density lipoproteins, LDL, along with platelets and other blood components. Over time, these accumulating deposits coalesce and grow into the formidable plaques that progressively narrow and stiffen your arteries. Crucially, this insidious process typically commences many years before anyone officially diagnoses you with diabetes. Even mild prediabetes, where your glucose levels are only slightly above normal, is sufficient to silently injure the endothelium over an extended period. The second formidable adversary to vascular health is smoking. Cigarette smoke is a complex concoction containing thousands of chemicals, dozens of which are unequivocally identified as cancer-causing substances. However, in the context of stroke risk, the primary concern lies specifically in their detrimental effects on the endothelium and the intrinsic properties of the blood itself. With every single cigarette consumed, a barrage of toxic compounds assaults the inner surface of your blood vessels, inducing direct chemical damage and triggering an inflammatory response. Concurrently, the nicotine and carbon monoxide present in cigarette smoke render your blood thicker and stickier, significantly increasing the ease with which platelets clump together and clots readily form. When you combine a damaged, inflamed vessel wall with thick, sticky blood, you create an almost ideal environment for a clot to eventually plug a critical brain artery.
This is precisely why smokers face roughly 2 to 4 times the risk of experiencing an ischemic stroke compared to non-smokers, who may have otherwise similar cholesterol and blood pressure readings. Blood pressure introduces yet another layer of potential confusion, because the prevailing myth here often runs in the opposite direction. Many individuals have heard that stroke is associated with high blood pressure, leading them to be terrified of a high reading, and conversely, relieved when their pressure is low or within the normal range. While chronically high blood pressure, or hypertension, is undeniably one of the strongest risk factors for stroke because it physically stresses and weakens vessel walls over years, thereby accelerating plaque formation, it is also the main precipitating factor behind hemorrhagic strokes, where a vessel literally bursts. However, there is a significant twist. An ischemic stroke often occurs not at the peak of blood pressure, but rather at a relative low point. Visualize a brain artery that is already narrowed by more than half due to the presence of a plaque, much like a water pipe that has been squeezed tightly in the middle. As long as the pressure within the circulatory system remains sufficiently high, some water will still manage to squeeze through that constricted segment. But if the overall systemic pressure subsequently falls, the flow through that narrowed point can dramatically drop to almost zero. This is particularly problematic if a small clot has already become lodged there and the system lacks sufficient push to propel it along. During the natural course of the night, while you sleep, blood pressure typically falls by approximately 15 to 20%. This is a normal physiological dip, not an indication of disease. If you already possess an artery narrowed by plaque, that physiological nighttime drop in blood pressure can be sufficient to transform a partial blockage into a complete cessation of blood flow, especially if a clot has formed on that plaque while you were lying quietly. This physiological phenomenon is one significant reason why some individuals go to bed feeling perfectly well and then awaken with debilitating stroke symptoms, or why they are sometimes discovered in that condition in the morning. Age, too, plays a critical role, but not in the simplistic "stroke is only for old people" manner often heard at family gatherings. While it is true that stroke risk rises significantly after the age of 50 and roughly doubles with each successive decade, with dominant causes in older adults tending to be atherosclerosis, plaque buildup, along with long-standing high blood pressure and various heart rhythm problems, it is crucial to recognize that approximately 10 to 15% of all strokes occur in individuals younger than 45. In these younger patients, medical records consistently reveal a different set of primary drivers, including congenital vessel abnormalities, bulging weak spots in vessel walls known as aneurysms that can rupture, inherited clotting disorders, various autoimmune diseases, and trauma to the head or neck. Another profound insight worth understanding is that the speed of vascular damage inflicted by the same risk factors notably changes with age. After roughly 40 years of age, the rate of plaque buildup and endothelial injury caused by factors such as smoking, chronically high sugar, or elevated blood pressure tends to accelerate to about twice the pace observed in one's 30s. This acceleration is a primary reason why medical professionals adopt a more direct and assertive approach concerning risk factor control as patients progress through their 40s and 50s. Therefore, considering one's current age is vital, as it directly influences how quickly your blood vessels respond to the same risk factors and shifts which specific causes of stroke are more likely to be relevant in your unique situation. This individualized perspective is paramount for determining what you and your doctor should be diligently paying attention to. Now, let's address the most practical and immediate question. What exactly should you do if you have already experienced even one of those 5 warning episodes, regardless of how minor it felt or if it vanished in under 10 minutes? You possess a critical window of approximately 72 hours, during which a substantial amount can still be done to prevent a full-blown stroke. The objective is not to descend into panic, but rather to utilize this precious window effectively.
Stroke specialists frequently emphasize the paramount importance of not being completely alone after a suspected transient ischemic attack. This is a situation that warrants proactive planning with your family and your doctor, particularly if you live by yourself. Should another, more serious episode occur where you suddenly find yourself unable to speak or move, you will critically need another person present who can witness the event, promptly call emergency services, and reach you quickly. Many individuals find it beneficial to inform a close family member or friend about what transpired, and ensure that someone can easily reach them over the subsequent couple of days. This is a perfectly reasonable point to discuss with your healthcare provider. Additionally, established stroke guidelines strongly advise against driving yourself after a possible TIA. Losing vision or control of an arm for even a few terrifying seconds at highway speed poses a life-threatening risk not only to yourself, but to everyone else on the road. It is highly advisable to proactively discuss with your doctor what transportation plan makes the most sense for your specific situation should something like this ever happen, thereby removing the temptation to simply drive yourself in. Checking blood pressure is typically among the very first steps in almost any acute medical situation. If you or someone near you can measure it, and the top number, systolic pressure, is around 180 or higher, and the bottom number, diastolic pressure, is around 110 or higher, that clinical picture aligns with a hypertensive crisis, which is far more serious than merely elevated blood pressure. A crisis of this magnitude is itself a potent warning sign for an impending stroke, and calling emergency services immediately is what standard guidelines frequently recommend. It is prudent to ask your doctor explicitly about this threshold so that you are aware in advance when to treat it as a medical emergency. One rule from stroke medicine is unequivocally strict. Never, under any circumstances, initiate blood-thinning drugs such as aspirin, anticoagulants, or similar medications on your own, based on a friend's advice or anything you may have read online. As previously discussed, there are two primary types of stroke: ischemic, where a vessel is blocked, and hemorrhagic, where a vessel is actively bleeding. While thinning the blood can be beneficial in certain ischemic situations, in the context of a hemorrhagic stroke, it can tragically exacerbate the bleeding, making it faster and more extensive, which can lead to a person's death more quickly. The only reliable method to differentiate between these two types of stroke is through brain imaging, typically a CT scan performed in a hospital setting. No doctor can simply observe someone and be 100% certain which type of stroke is occurring without the aid of a scan. Therefore, instead of attempting to self-treat, the correct and safest course of action is to seek immediate medical evaluation and allow a qualified medical team to make these critical decisions. You are absolutely empowered to ask your doctor in advance how they would prefer you to act if you ever suspect a stroke. While waiting for help to arrive or en route to medical care, body position matters significantly. Lying down is generally preferable to sitting bolt upright, as it promotes better blood flow to the brain. Many clinicians suggest a comfortable, flat position with the legs slightly elevated above chest level to support circulation and reduce the heart's workload. The head should be maintained in a neutral position, neither sharply bent forward nor thrown back, to ensure that neck vessels are not kinked. It is also wise to refrain from smoking, consuming alcohol, or exposing oneself to hot baths or very hot showers in that moment, as sudden vessel dilation in an already unstable circulatory system can potentially worsen the situation. Always double-check these recommendations with your own doctor. Maintaining a written, easily accessible list of all the medications you take regularly is a small yet immensely helpful step that can save precious minutes for emergency medical teams. It's something many people misunderstand. If 72 hours elapse and no new episode occurs, that does not automatically mean you are in the clear. Instead, it signifies that you have been granted a valuable second chance, and you still have a responsibility to utilize it wisely. There are 3 specific medical evaluations that are highly reasonable to inquire about at your next medical visit if you have experienced any of these warning signs. Each of these tests examines a distinct piece of the complex stroke puzzle. The first is a specialized ultrasound examination of your neck arteries, known as a carotid duplex ultrasound. Unlike a basic ultrasound that merely visualizes structure, duplex imaging provides both a detailed anatomical view of the artery and crucial information about how blood is flowing through it, including whether the flow speeds up and becomes turbulent at a narrowed segment. If the carotid artery is found to be narrowed by more than approximately 70% due to plaque buildup, doctors classify this as a hemodynamically significant stenosis, meaning the narrowing is severe enough to seriously impair blood flow. At this critical juncture, the question shifts from, "Will a stroke ever happen?" to, "When will it happen if nothing changes?" In such cases, surgeons may suggest a procedure called a carotid endarterectomy, where they surgically open the artery and meticulously remove the plaque. While it might sound dramatic, in modern medical practice, this is a routine and highly effective surgery that demonstrably saves tens of thousands of individuals from stroke every single year. If you have recognized any of the risk factors or symptoms discussed, initiating a conversation with your doctor about a carotid ultrasound is a very reasonable and proactive step. The second crucial test is a blood analysis known as glycated hemoglobin, or HbA1c. This test measures the amount of ordinary hemoglobin, the vital oxygen-carrying protein found in your red blood cells that has sugar molecules chemically bonded or stuck to it. The higher your average blood sugar levels have been over the preceding months, the greater the proportion of your hemoglobin that becomes sugar-coated. This is why the HbA1c test provides an accurate reflection of your average blood sugar levels over approximately a 3-month period, offering a much more comprehensive picture than a single morning snapshot provided by a fasting glucose test. You cannot achieve a favorable HbA1c result simply by having one perfect fasting glucose reading the day before the blood draw. It reflects long-term control. This test is particularly adept at identifying that ambiguous gray zone termed prediabetes, where blood sugar levels have been sufficiently elevated for a prolonged period to cause subtle damage to blood vessels, even though a formal diagnosis of diabetes has not yet been made. The diagnostic cutoffs are clear. A glycated hemoglobin reading under approximately 5.7% is considered normal. Readings between 5.7% and 6.4% indicate prediabetes, and a level of 6.5% or higher typically corresponds to a diagnosis of diabetes. If you have never undergone this test, or if it has been many years since your last one, this is an easy and important topic to bring up with your doctor, especially if you possess any of the established stroke risk factors. The third vital investigation is Holter monitoring of the ECG. In simple terms, this involves a 24-hour continuous heart rhythm recording, in contrast to the brief 10 or 20-second electrocardiogram typically performed in a clinic. For this test, you wear a small, portable device for an entire day while you proceed with your normal daily routine. The rationale behind this is straightforward. Some dangerous heart rhythm problems are paroxysmal, meaning they come and go intermittently. They might only manifest once or twice a day for a few brief seconds and would be entirely missed by a short, static snapshot ECG. The most significant rhythmic culprit for stroke is atrial fibrillation, or AFib. In atrial fibrillation, the upper chambers of the heart, known as the atria, cease to beat in a steady, organized, and effective manner. Instead, they quiver chaotically and erratically, sometimes at astonishing rates of 300 to 400 contractions per minute. When this disorganization occurs, blood does not empty smoothly and completely from the atria. Rather, it churns and swirls instead of flowing in a laminar fashion.
In this turbulent, swirling blood, clots form with remarkable ease. These dangerous clots can then dislodge from the heart, travel upwards to the brain, and become lodged in a cerebral artery, leading to what is known as a cardioembolic stroke. These types of strokes tend to be particularly severe. Many individuals living with atrial fibrillation do not experience dramatic or overt symptoms. At most, they might notice
Occasional skipped beats, brief fluttering sensations in their chest, or they may mistakenly attribute these feelings to stress or caffeine. Holter monitoring is specifically designed to catch these often hidden and transient episodes of abnormal heart rhythm. If AFib is detected, there are well-established and highly effective medications called anticoagulants or blood thinners that, when prescribed and carefully monitored correctly, can significantly reduce the risk of stroke in this condition by approximately 60 to 70%. This is not an inevitable outcome. It is a substantial risk that you and your cardiologist can actively work together to mitigate. Stepping back to gain a broader perspective, it becomes unequivocally clear that a stroke is not an unpredictable lightning bolt striking from a clear sky. It is, in fact, a largely predictable event that typically occurs after many years of silent and progressive vessel damage, and crucially, it very often announces its impending arrival through specific warning signs. You are now equipped with knowledge of the most critical of these: brief, temporary blindness in one eye, sudden, unexplained, one-sided numbness or tingling, an abrupt loss of coordination manifesting as a drunk walk, a sudden and serious breakdown in speech, and the less common but important combination of vitiligo paired with new, unusual, and intense headaches. The appearance of any of these signs for the first time, even if they quickly vanish within a minute, constitutes a compelling reason to urgently consult a medical professional and specifically inquire about those three essential evaluations: a carotid duplex ultrasound, glycated hemoglobin, HbA1c, and Holter ECG monitoring. On the prevention side, a substantial body of research consistently links several proactive measures to a significantly lower stroke risk. Maintaining blood sugar levels within a healthy range and actively catching prediabetes early are critical steps that protect the delicate endothelium and effectively slow the progression of plaque growth. Meticulously managing blood pressure with the guidance of your doctor, focusing not just on aggressively lowering it at all costs, but strategically avoiding both extremes of very high and very low pressure, reduces strain on your blood vessels and diminishes the risk of both hemorrhagic and ischemic strokes. Quitting smoking, with appropriate support if needed, eradicates a constant chemical assault on your arteries and can reduce your ischemic stroke risk by a factor of roughly 2 to 4 over time. And perhaps the most profoundly important principle to internalize is this: do not wait for brief brain symptoms to simply go away by themselves. In the critical world of stroke care, you typically have approximately 72 hours to act decisively. Following this detailed discussion, here is a clear and actionable path forward. If you recognize any of the 5 warning signs discussed, even if they occurred months ago, meticulously write them down in plain language and present that comprehensive list to your doctor. Do not rely solely on memory. Directly ask your doctor whether you should be evaluated for transient ischemic attacks and whether a carotid ultrasound, glycated hemoglobin test, or Holter monitoring makes sense for your specific case. If you have identified yourself as having existing risk factors such as high blood sugar, elevated blood pressure, a history of smoking, or autoimmune conditions, utilize the knowledge you have gained here to engage in a more specific and informed conversation with your doctor about comprehensive stroke prevention, rather than simply accepting a generic reassurance of "everything looks fine" without actual numbers or a concrete plan. Everything covered today is provided for your understanding and educational enrichment. Your individual situation is unique to you, And leveraging this information as an informed starting point for a genuine conversation with your doctor will invariably be more beneficial than attempting to manage complex medical issues on your own.